We rolling?
Owen.
We on, baby. Mic check.
All right. Welcome to another episode of The Playbook, the ultimate guide to men's health. My name is Manny Camber, your host, and today, a returning guest, Dr. David Grosiak,
How you guys doing?
owner, operator, CEO of Game Day in Acco, New Jersey.
Yep.
This podcast, of course, is brought to you by the Swedesboro location. Today, we have a couple of very interesting topics. We want to show the relationship between testosterone replacement therapy and potential additions. One being GLP1 peptides. You know, your very common semaglutide, tirzepatide. A lot of people know them as Ozempic. So Dr. Dave is going to go deep into that territory and really explain all angles and see how they can benefit you in your weight loss journey, how they can help when combined with testosterone therapy, and how they can be almost like a synergistic effect when trying to lose weight.
Yeah.
So with a lot of people trying to lose weight this time of year, New Year's, Game Day, of course, in Swedesboro is running Acco, not gonna
Atco.
No, but
Oh,
Acco
yeah.
also?
We're gonna do absolutely New Year's
right.
specials for sure.
All right, awesome. Yeah, so there's going to be a 20% off GLP-1s for this weight loss season in the month of January. So look for tirzepatide or semaglutide and bring that up when you go into your visit. Speak to your Swedesboro or Acco Game Day locations. So, all right.
Ready to
Let's
rock?
get into it, man.
All right.
So this time of year, right? Everyone's trying to lose weight. Past maybe, 2 to 3 years, it's been this miracle drug, man. It's Ozempic, semaglutide. Now, then next came tirzepatide. So Game Day, of course, has both of them. But for the most people that don't really know the science behind it or any more than the Hollywood drug, right? To lose weight. That's kind of what
Oprah.
it's. Yep.
Oprah's on it.
Yep.
Big audience.
So yeah, give everyone a good description, I guess, and tell them what it really is.
I'm sure a lot of people know about the GLP-1s. I mean, they've been in the news. They've been around for a long period of time. And
How long? Because it's been in the news recently.
I mean, they've been out for like the previous GLP-1s, the duaglutide, the liraglutide. Like they've been out for, I believe, since 2004 or 5 when those initial GLP-1s came out.
It's like 20 years.
Yeah, they've been out for a longer period of time. Kind of originally used more to treat diabetes. It was really when you got into the semaglutide where people were noticing more of the weight loss, and then it became more of a weight loss medication as well as a diabetic medication. Okay. And so that's the reason that one's a little bit more popular, just because the amount of weight loss people were having on those medications. So yeah, we do all that at Game Day. We do the semaglutide, we do the tirzepatide. We get them from our compounding pharmacies, and there's a little nuance and difference between the two. Now, Ozempic for the weight loss has been out for a longer period of time than the tirzepatide, and that one itself is just the GLP-1. And people always kind of wonder how the GLP-1s work, and you kind of hear about them, quieting the food noise, where you're kind of not looking for your next meal. Kind of works on even some of the reward centers in your hypothalamus in your brain. So you get that, food noise that quiets down a little bit too. And they've also shown, even for like substance abuse disorders, that it has some benefits there too, because there's actually that kind of reward center too for food that people have.
Dopamine.
The dopamine, the serotonin and everything after you get that good meal, especially ice cream, something good with kind of higher in sugar and higher in fat content and everything.
That all makes sense.
Yeah. So you kind of get that quieting of that food chatter, and then just even where you're kind of looking to kind of graze on meals from time to time. So it kind of quiets that down a little bit. Yeah. And then it's also going to decrease, like GLP-1 is a naturally occurring peptide in your body that also delays gastric emptying. So it's going to decrease or it's going to increase the amount of time that the food is in your stomach. It's going to decrease.
Does that decrease your metabolism?
No.
Okay. I just want to clarify that to people. It's not necessarily going to lower your metabolism. It just lowers the gastric emptying. So it keeps you fuller longer, more or less.
Yep, exactly. So feeling full a little bit longer than normal. So you're just kind of not looking for that next meal. And to me, that food chatter aspect of it too, and just kind of quieting down that food noise, I think is huge for a lot of people too.
Yeah, I wish I knew about this during my bodybuilding days back in the day, because I've grown up with ADHD my entire life.
Yeah.
And they prescribe stimulants to help subside some of the side effect, some of the symptoms. But
Because I think the slowing the gastric emptying time, like kind of keeping you feel full a little bit longer, is one aspect of that. But people will even eat when they're not hungry, and I
no,
think that's a
they're
little bit more of that
bored.
reward
That
center
reward.
aspect of it.
Yes.
So that kind of helps out and kind of like two of those fronts in regards to that.
Yep.
So that one's been around for a long period of time now. Then you get into the second level, the tirzepatide, which is the GLP1 and the GIP. So the GIP is the glucose dependent insulinotropic polypeptide. So that kind of has a couple different effects on it as well. Now the GLP, well, semaglutide has a little bit more of a stronger GLP1 interaction. The tirzepatide has a little less so because it also has that GIP component on that.
So would that mean a little less nausea, a little less side effects?
Exactly.
Yeah.
Exactly.
Cool.
Yeah. Because when
Cool.
you have like more of that stronger GLP-1, exactly, you're going to have a little of that nausea and vomiting. You'll kind of see people also do have constipation, and you could have a little diarrhea with that. So you kind of see both of
The
those.
whole spectrum.
Yeah. Yeah.
Just get yourself some Pepto and you're all set.
Yeah,
Head to toe.
exactly. So if you're that person that kind of has generally that slower gastric emptying time, if you have, hypothyroidism, they're kind of more prone to constipation as well.
Yep.
Then you gotta bulk up that diet, get a little bit more fiber in there to kind of get you going along in regards to that. But you do see patients that will also, on the flip side of that, will have a little diarrhea. I would say that's, a small minor amount in regards to that.
Sure.
But
and it may not even be guaranteed because of that, because people get diarrhea all the time with their poor diets, their dehydration. It's just
all across the board, especially this time of year, all the viral kind of stuff going around and everything. And but yeah, that GIP component to it, that'll kind of help more, like a little bit of more like lipolysis and metabolism with the glucose. So you kind of get the delayed gastric emptying time. And then that GIP component will kind of gets a little bit more of that increased metabolism aspect of it to kind of just burn a little bit more fuel, essentially.
Increased metabolism. So when you're saying the lipolysis, does it make
Lipolysis, yeah.
Does it make that's just fat burning, right? It's just fat burning.
Yeah,
All right,
kind of
so
mobilizing it from fat tissues, liver stores.
So it doesn't necessarily make the fat or our body's more prone to burning fat, or it doesn't direct it a certain way. But
it's kind of like, to me, that just kind of, it's, energy currency, just kind of burning a little bit more fuel with that.
Got to get that ATP. Yeah. There you go. So we were talking, thank you for that. That was,
Sure.
I realized you just kept going, and I was just like,
yeah.
All right.
Yeah. Get it rolling.
So one of the main reasons, someone comes to game day for testosterone, right, is, for that vitality, that strength, right? Well, GLP-1s have gotten a little bit of a bad rap about people either using them too long or abusing them, going too far with them, or using them for what even the people that use it responsibly. They use it for the time they need to. And then when they stop, they're frail.
Yeah.
So and they've lost all this weight, a ton, right? But they've probably also lost a significant amount of lean body tissue.
Oh yeah. I mean, we've talked about this before. I mean, the main thing, and we kind of talk about this, the main thing is the, resistance training whenever you're on that. So if you want to, avoid any of that muscle mass loss, kind of, for one, it's like, you got to increase your activity a little bit, which can be hard sometimes on some of those medications because you're not eating as much. You can feel a little bit of fatigue with that. But if you're going to kind of do anything, to me, really the resistance training is what you want to do to try to maintain some of that muscle mass. And then it's also, just having realistic goals, I think, with some of these medications. You kind of hear all these stories about people losing a ton of weight, and it's kind of, having that little bit slower weight loss, really kind of like a pound or two a week in regards to like your fat loss, not kind of trying to do that 5 pounds or 20 pounds in 1 month.
Yep.
When you're doing that, that's when you're going to get in that catabolic state. And then your body's going to burn more of that muscle mass to create energy.
If we're burning fat, does it count as catabolic? No, right?
It's still catabolic.
It is catabolic. I was just kind of curious.
As long as you're not building, kind of putting on fat, it's still breaking it down. You're breaking it down for, essentially, lipolysis, increasing the amount of glucose you have, fatty acid oxidation, so your cells can kind of run on the energy. So yeah, still catabolic state, but it's kind of using it right, and if you're going to be on those medications, getting your protein intake, avoiding the kind of junk food, so if you're doing, these crash diets, even if you're not on a GLP-1 and you just starve yourself, and you're not eating well, I mean, you're going to lose muscle mass like that.
And there's a difference between starving and fasting.
Yeah.
Right? Fasting is absolutely nothing for a structured period of time. Starving is eating 2 pretzels in the morning, waking up your metabolism just to shut it off with
Yeah.
a coffee 4 hours later,
Yeah.
and then waking it up 4 hours, like 3 hours later with a half a muffin.
Yeah.
All right, and then thinking that you dieted and didn't need it. No, you just completely destroyed your metabolism.
Right.
That's starving yourself.
Oh yeah. Either
Fasting,
way,
yeah, exactly.
in the end, with all these meds, you're trying to get yourself in a catabolic state or a calorie deficit, essentially.
Yes,
Right. I mean, that's kind
I've
of what
always,
you're
I've
trying to do.
always, as a bodybuilder in me, I've never seen catabolic as anything other than the taboo. Like,
Yeah.
that's
Yeah.
why I kind of go like, wait, if we're burning fat, it's still catabolic, right?
Exactly. Right.
Yeah.
And so I mean, to me, it's kind of doing it responsible. And for one, it's getting in front of a provider, somebody like Dana over at Swedesboro that's been doing this for a long period of time now.
Or you.
Kind of just getting an experienced physician myself, at the
Exactly.
ACO location. And it's just to me kind of having realistic goals. And to me, you kind of want the minimum effective dose without side effects that's getting you the results.
Yes, and that is something that we want to make very clear. Here at Game Day, we are not trying to push stuff. We're not driven by big pharma or anything like that. Your doctors, you're not going to have your scheduled increase of your dose 3 weeks from your first. You're not going to go 0.25, then 0.5, then 1.
Yeah.
No. If you're still feeling the effects at 0.25, ride it out. There you go.
Yeah.
There's no sense of going up.
There's kind of no way around it. I mean, these medications aren't cheap, so as you kind of go up in the dosage too, it's going to go up in price at most locations, most kind of everywhere. That's just kind of the way it works with some of those medications. So to me, the minimum effective dose to get you feeling good, getting your results. And then if you plateau after that, if it's kind of the weight's not falling off, if you're kind of, don't lose any weight for a month, then you could kind of go up on the dose. But it's something that you should talk about your doc with, not just increasing your dose.
Yeah, because you know what? Think of the scientific method: controlled variables, right? Independent variables.
Yeah.
Keep things controlled. It may not be if you start to plateau, right? There's a lot of things changing in your body. Maybe you keep that. Maybe you change something in your diet.
Yeah.
Maybe you change something in your routine, your daily routine, your physical routine, that will break that plateau, and you'll stay at that minimum effective dose.
Yeah. Yeah. And everyone really is different. I've seen, patients that are on the same dose. Like if you're talking about the tirzepatide, so you have one person that comes in, you start them at that 2.5 milligram dose, and kind of right away they're losing weight, or they're having a lot of nausea, because they're not eating secondary to that. And then you have other patients that you put on the 2.5 milligrams, and they're not really seeing the weight loss
They're feasting still, yeah.
Yeah, until you really kind of get to that 7.5, 10 milligrams. So the way somebody's are going to respond is very different. I mean, it's not a one size fits all, so I can't kind of tell you exactly how you're going to respond. So that's really just communicating with your physician or your provider as you're kind of going along and kind of making changes.
Does it have to do with insulin tolerance or sensitivity?
I don't know if I can tell you, honestly. I don't know if it's the amount of GLP-1 receptors the patients have. I couldn't tell you why somebody has more negative side effects versus the other person. You just see it,
Well, I mean, the negative side effects, sure. I mean, a lot of people are, more susceptible to nausea. They have an upside down stomach, some people, but
yeah.
I meant if a 0.25 really works incredibly well on someone, let's say 0.25 works incredibly well on
that'd be the semaglutide
on 100 and yes, exactly.
Yeah,
Not a 2.5.
Yeah.
Let's say 0.25, right, works very well on a 180 pound male. And for some reason, a 1.0, right? A 1 is on a 145, 150 pound woman. She's up there. What determines, is it the receptors, or is it the binding, what gets used to it? Like the body, I know, acclimates, or right, it starts to.
You're saying why?
What determines the overall effect and how intense it is? Is it because it's supposed to release a certain amount of insulin?
Well, there is a glucose dependent insulin response, which is why you kind of use it in diabetes. But that's also the reason that glucose dependent insulin response, or that's one of the reasons you also don't get the hypoglycemia with those medications. I mean, if you're on some other medications, you're not eating, maybe you could dip down, you don't really see that hypoglycemia, which is why I can use it for the weight loss. But are you saying why would?
Yeah, so you said so it's affecting our body's insulin, right?
Yeah. Yes, absolutely. It stimulates your pancreas.
Exactly.
Yeah.
So
Yeah.
now in doing so, right, theoretically, the more drug you administer, the more response you
Sure.
should get in return,
Yeah.
right? So then you have those two controlled. That you have this as the dose increases, the effect increases.
Yeah.
Now, this effect may be half of what this person needs, and it's twice as much as this person needs, based off of their what I theorize just now. What it's like insulin sensitivity, maybe. That's what it kind
I
of
don't
like.
know. I'm not sure, to tell you the truth.
I was gonna say
I just
so.
kind of, you see it anecdotally, like from patient to patient that you're treating, but I couldn't tell you why, kind of looking at this one person, that they're going to have this effect versus
Or
them.
defining like a correlation, like between someone could have pasta at lunch,
Yeah.
knock out 45 minutes later. Another person can have pasta at lunch, same thing,
Sure.
right? And maybe power through, not as bad. They don't
Yeah.
have that much of a spike there or that much of a response type
Mm-hmm.
thing.
Mm-hmm.
I say, yeah. So like, I was hoping to find some sort of correlation, but I guess not.
Not that I know. Not that
Like,
I
hey,
know.
if you like potato chips,
Yeah.
you're going to be a one or more. If
Yeah.
you don't like potato chips, you'll be that 0.25. No.
Yeah. I'm sure
I
there's,
wish,
a,
yeah.
there's a lot of variability to each patient. That person that's coming in, that's going on that medicine, are they somebody that's like 400 pounds and really struggles with the weight loss, for somebody that's kind of, that 150 pounds and they're trying to lose a few pounds for, their wedding or whatever events kind of coming up. So it's probably just some of their inherent metabolism and physiology of why they're getting those different results. But I haven't seen one particular thing that kind of you can determine prior to, like, how they're going to respond to that,
Yeah, Brad.
Yeah. But I'm sure you build up a little tolerance as you go along.
No, yeah, I'm sure. I mean,
Yeah.
like, so that's the thing. Same thing with pain in the body, right? You can have some nagging pain in your knee or whatever.
Yeah.
Eventually, after 5 years of constant chronic pain,
Yeah.
your body almost masks it. It's there, but it's certainly not nearly as much as it was before.
Right.
And that's, taking a painkiller for like a shoulder injury. All of a sudden, that feels good, and you're like, and that's where like the euphoria comes from, and that's the danger. That's where like that's how I kind of explained it to people. Like, how do you get hooked on painkillers? Because you have a lot of pain that your body pushes down, gets used to. So our bodies definitely get used to a GLP-1. But you mentioned obesity, right? And men with metabolic syndrome, women with metabolic syndrome as well. Do you typically see low testosterone as it correlates with these syndromes or diseases?
Oh, absolutely. Yeah. If you're obese, overweight, you're generally are gonna have a higher increased risk for low testosterone. Absolutely. Just kind of being overweight and having that metabolic syndrome, you're not going to function your endocrine system as it normally should. So absolutely, you see patients that are more obese that are going to have that lower testosterone. So even the guys that come in, symptomatic wise with a low T, I mean, some of the strategies you can use is really kind of just overall health, like using the GLP-1 to kind of get a little bit of your weight down, feeling a little bit better, get into the gym, move a little bit more, increase your resistance training, kind of lifting some of those heavy weights to kind of boost up your T. So you can see that change over time.
And anyone listening, you will not get too big if you lift weights.
No.
I promise you.
It is really hard to do.
Yes.
It is a lot of discipline.
You will not get too big.
People always say they don't want to get bulky or this and that, and it is not easy to get bulky.
No.
Yeah. It takes a lot of food, a lot of protein, a lot of hard work.
So from an ER, you said you worked as an ER.
Yeah.
Yep. Is it medical ER physician?
Been working at the Virtual Voorhees Hospital 14 years as an ER doc, another 4 years with residency, so 18 years total.
So what have you seen, over the years in regards to GLP-1s, of maybe those, people that abuse it, take it too much? Because this is you don't see it too often, but it can have an extremely negative effect if abused or misused.
Yeah, most commonly people come in just really with the nausea and vomiting. Generally when either not always with the lower doses, sometimes when you go up, and what you see too is don't use your family or friends' medications at home. So patients do that, like where their mother's prescribed it or their father or someone else, and then they take some of the medication and they might know the starting dose and they're taking a higher dose. I've seen that before in the ER. Yeah, where they're taking someone else's medications, and they might not know your other medical history or what other medications that you're on in regards to that. So that happens. The severe side effect, which is very rare now. In the past, 5-6 years since, the semaglutide has been out a little bit more. One of the things that can happen is pancreatitis, because it does stimulate your pancreas. And pancreatitis is where your pancreas gets inflamed. It's basically a metabolic disorder. You can have a lot of different electrolyte abnormalities,
It's like
dehydration.
it just gets punched. Just
Yeah.
wake up, and then it just starts to. It just doesn't stop. Or
Yeah. Well,
is
generally
it harmed? I think right, because
it's
it's like
inflamed. I mean, it's pretty inflamed. And when you have that, I mean, it's painful. When you're having like the
Mhm.
nausea and vomiting, I mean, you're generally not having pain with that. Although, if you're vomiting a lot,
you
you're
get a
getting a little
little
discomfort.
stomach. No, but you have a sharp, piercing pain that
It's kind of right below your sternum, kind of right in
Oh,
that
right there.
epigastrum. Yeah. And you'll see, I mean, your lipase will be very elevated. Patients will get CAT scans, and you can see on the CAT scan that it's all inflamed. So out of all the years that, the semaglutide has been out now, I think maybe 3 or 4, I don't even know if it's as much as 4. I was going to say 2 or 3 cases of pancreatitis. And there's a lot of patients on these medications. So, and that's all just anecdotally. That doesn't mean that's how many patients came through my hospital. There's other docs that are seeing patients too, but that's just my experience.
Okay. I mean, okay. So, and I mean, would you say that that was developed over time, or kind of an acute result?
I can't remember honestly when they started the medication, those cases. So I don't know if it was new.
I'm not going to mention the person, but I can speak specifically. I do know someone close to me that and the dose was
Higher.
It was four times.
The semaglutide?
It was semaglutide.
Uh-huh.
They were on a Mounjaro or something that before,
Yeah.
right? I think they had been off for a month.
Yeah.
And they tried like, oh, well, I haven't been off that long. And then they kind of just started, they almost did a parallel,
Yeah.
right? Like even like, oh, that's one. I'm like,
Oh.
immediately I'm like, that's probably not right.
Equivalent
But,
doses, you're saying? Because like the one was
correct. I mean,
2.5, 5 milligrams, and then they injected that much of semaglutide.
yeah. So they did something like that. They ended up doing
move.
4 times. And so they thought their first initial dose of semaglutide of being one milligram
Yeah.
was where to be. And sure enough, within 24 hours, pain, and then for the next 18 hours, I would say, severe pain. They went to the hospital. A very acute case of pancreatitis.
Oh wow! Were they in the hospital for a while, or
hospital? No, urgent care but they told you can't really do anything. All we can do is give you nausea tell you to take nausea medication, because they were throwing up.
Yeah, when you get pancreatitis, I mean, that's something you get admitted to the hospital for. It's bowel rest. There's nothing to eat or drink. They watch your electrolytes, give you IV fluids. It's kind of, quieting down that whole GI tract, the endocrine system. So
that person probably should have or could have. Yeah. Because it was like 4 straight days of.
Yeah. And there's a large array. There's the mild pancreatitis, and then there's severe pancreatitis. And you don't want to mess around with that.
No.
So, make sure you're talking to your doc and dosing it correctly. 100%.
Yeah. Well, I guess one more. Who's the ideal candidate for combined TRT and GLP-1? So who would see the biggest benefit?
To me, it's really patient dependent on what your goals are. I think for kind of the TRT, I do think that's the foundation for guys overall, if they're low, to kind of getting that energy and feeling well. I think it's great to pair with the GLP-1s if you want to use those medications for weight loss to help maintain some of that muscle mass. And they can cause a little bit of fatigue, the GLP-1. So if you're experiencing that and you're low T, that testosterone can help out with that energy overall and kind of give you that drive to do the resistance training, give you that executive function, that kind of go-getter attitude to get to the gym. But you don't have to pair them together. But together, I do think that guys that are low are suffering from hypogonadism, that also have some excessive weight, that it is great to pair with TRT to kind of help out overall with just your muscle mass.
I mean,
yeah, and your recovery.
One of the main reasons we created this whole podcast was with the intent of discussing topics that men notoriously avoid, that there's just not enough knowledge on it, because a lot of guys just don't speak about it. They don't ask about it.
Yeah.
And taking semaglutide or taking Ozempic, it can be portrayed or it can be taken as, I'm taking a girly drug or whatever.
Yeah.
Or I'm taking, I need assistance or help. It's like,
No one wants to say that they're on it.
no, exactly. But why? Why not?
Yeah. To
Why
me,
not?
this is a destigmatizing. It's about health kind of overall, and talking about it to your friend or someone else and like normalizing some of these things,
Yes.
I think can be beneficial for patients.
And weighing what's important. You're not going to be like, I've always used this example. It's like pointing or laughing at the fat guy at the gym. If people that are like, oh, geez, look at that fat guy. Like,
Hey, he's there, man.
Exactly.
He's there.
No,
Right?
if he was laying on a couch eating, you would just walk right by. You're
Yeah.
like, oh, yeah. But now, since he's busting his butt, extremely
applaud him.
sweaty, right? Awkwardly moving around, like that's it's contradicting, right? So, guys, get over that stigma, right? It's not, you're not any less of a man if you're on testosterone replacement therapy. In fact, you're going to feel like a hell of a lot more. Just trust us. If that's how your mind is, if you think you're going to be less of a man on it, I challenge you to do it and get back to me on that one.
Yeah.
And if you think you're less of a man, if you have to use some weight loss assisting drugs, like a GLP-1, let me know when you're 25 pounds, when you lose 25 pounds.
Yeah, it's not easy. This stuff is not easy, and that's why some of these medications and these clinics and doctors are around to help people out with that. If it was that easy, everyone would just be doing it. But
correct,
it's not that easy.
No, it's not. Yeah. And if you're willing to, sacrifice your time, effort, just to put yourself first, we're here at Game Day to help you as best we can.
Yeah, come on and swing by.
Yeah, man. Just again, we want to remind you in the month of January, come stop down at either ACO or Swedesboro locations. We will be offering 20% off GLP-1s, peptides for the month of January to kickstart your weight loss journey in the new year. New year, new you. I want to thank the Frosted Nug dispensary in Carney's Point for letting us use this podcast studio as they so frequently do. Thank you guys. This is incredible. This has been Manny Camber, Dr. Dave Grosiak.
Dr. Grosiak.
Yeah.
All right, guys. Have a great new year.
Yeah. Take care.
All right. Take care.